Guess we'll start. Good afternoon, and welcome to Making Technology Work for You, Not Against You. I'm Daryl Higa, Director of Planning and Project Management with Hawai'i HIE, and I have the honor and privilege of introducing our speaker. PracticeWise was started in 2003 by Julie McGovern. With a healthcare administration degree from the University of Hawaii West Oahu campus, years of practical experience in practice administration, revenue cycle management, and software implementation, Julie realized that there was a lack of clear communication and understanding between information technology vendors and the practices they served. She has been able to bridge that gap successfully for hundreds of doctors and their support teams. With the technology demands of electronic health records put upon doctors and their staff, in today's healthcare environment, the need for a technology and practice advocate has never been greater. Please join me in welcoming Julie McGovern, CEO of PracticeWise.
Thank you. Thank you. I'm gaining 10 pounds today. Thank you. Well, thank you for that kind introduction. You know, this topic, I was in the bathroom right before I came in here, and they have video screens on the sinks. And I was like, well, that's interesting. What's going on at the sink? So, of course, I beelined back over to the sink before I went shishi to see what was going on at the sink. And then I thought, what would happen if you walked into your doctor's office and there was a video screen in the bathroom when you go to do a clean catch? But then I thought, maybe that's not such a bad thing. I would think it would be animated, not real video, but human video. But you could literally use that kind of information in your office on a little iPad or something in your bathroom on the wall and teach people about hand washing and teach people about clean catch specimens, which it's really hard to read that thing on the wall and do it and understand. You could click on I'm a female or I'm a male and it'll bring up your video. And so that's what I just did in the bathroom before I came in here. I am always thinking about how to make technology automate your practice. Because my saying always is, if any monkey can do it, then let the monkey, which is the system, do it for you so that you, as providers, can continue to be doing the thing that you went to school for, which is treating patients, and your staff can be doing the things that they got their higher learning for, their experience for, which is taking good care of your patients, filing claims, working claims, all of those things, and not wrestling with technology and trying to figure out what should be doing what and when. Because I'm guessing most people didn't go to school to get an IT degree. So I'm always thinking, the bathroom was pretty funny when I went in there. How I got into this, just a little quick finishing of the intro there. I was a clinic administrator for a 16-doctor practice. We left Hawaii, moved to the mainland, like everybody does at some point in their 30s after you go to school and you find out you can't really make any money, and so you move on and go get a job somewhere else or whatever. And I was in Oregon, and I was working for a 16-doctor pediatric practice, and it was Y2K. Now, I'm like everybody else. I really didn't know that much about computers. The joke in our house was that if my husband wanted me to do something on the computer, he told our 3-year-old, who then interpreted it for me, what the yellow folder on the desktop was, so I could download the Blues Clues game or whatever. And so I'm responsible for Y2K purchasing of all new computers, putting in the infrastructure between 2 offices so that they could talk to each other, and changing software. And I was lost. The vendors would come in and do this talk, and it was like Charlie Brown's teacher. I'd be sitting in the back of the room going, I have no idea what they're talking about. I don't know anything. My husband's an engineer, so I'd go home at night and I'm like, can you tell me what any of these acronyms mean or what any of this is? And how am I going to tell my doctors that we have to spend $250,000 when I don't even know what it is I'm telling them? How do I defend this position? And so I decided I don't like to be in that position. I would learn the technology from the vendor's standpoint. So I went to work for a software vendor implementing software in clinics. And I realized there was a gap there. They would come in and they'd say to me, go in and just tell them what to do and to call us if they have any questions. Like, how would they know if they have any questions? We just shot a fire hose down their throat with information of, here's the software and it does these 12,000 things. and retain it all and call us if you have any questions. You wouldn't even know what to call about because you wouldn't know you have a question until something doesn't work, but you wouldn't know the ongoing day-to-day efficiency questions or how to get more proficient in the system. So I went to my boss and I said, can we start consulting with these customers? And I was traveling around the country at the time. So if I had to stay in a hotel, I would just stay at the clinic and work till 10 o'clock at night with the clinic management or the billers or whatever, and I'd help them. I'd say, listen, let's just go through the workflows and let me help you with your workflows. And then my boss said, you got to stop doing that. You're making them dependent on you. And I just thought that was weird. I just thought, don't you want them to know how to use the software and the technology we're putting in here? And their IT guys would come in and they'd squawk at them and say things, and the managers look at me and go, I don't know, should I have said yes to him or no to him? Because I didn't understand the words that came out of his mouth. So that's when I went, maybe there's a gap here. Somebody needs to fill the gap and understand what the clinic workflows are and understand the language that all these vendors are saying, what they're talking about. And so my customers actually talked me into becoming a consultant. And then I hired IT people who trained me in IT. And we just took it from there. And it's been a good marriage for us for 15 years now. So I'm pretty happy with what I do. And I love helping you guys get back to doing what you do and not be strapped to a computer and frustrated with it. Now, we're in the age of you're strapped to a computer whether you like it or not. So let's talk about that. This is what I hear every day. Get that computer out of my office. I just want to treat my patients. And I feel you. I get it. Most doctors don't type without looking. They're hunting and pecking because you didn't go to school to be a stenographer or typist or whatever. This is not what you were expecting, right? So what are doctors faced with right now? It used to be that the only thing you had in your office that you had to deal with was the practice management software. And frankly, the doctors didn't really interface with that. Somebody printed out your schedule for you out of the software and they highlighted over the patients as they came in. That was about as close as you got to interfacing with your software. So your front desk, your billers, and your nurses interfaced with the software, and you just went about your business. You charted, and everything was good. Now you've got electronic medical records. Some people have EMR and PM, practice management, in the same product. Others have two separate products with an interface between them. So now you're talking about 3 pieces of software and 3 failure points, okay? You've got clearinghouses because claims haven't been going on paper for years unless it's an Ohana claim, but everybody else goes electronically, okay? You've got email that you probably, I have doctors that have their .edu email address and they've been in practice for 15 years. So they weren't at a .edu since they were in medical school, but they still, they've never changed email addresses. And there's nothing wrong with that. It just tells me that they're not somebody who's engaged in using their technology because it doesn't matter to them. But now you have to do direct mail between EMRs. Your EMR has to be able to send a CCDA to somebody else's EMR. That's a form of email in a secure way, but it's EMR to EMR email. And then you've got all these things like meaningful use, patient-centered medical home, PQRS, COSIVA, all of that stuff. Again, hours for you spending time trying to figure out what you're doing with your technology in your office. So my first question is, raise your hand, don't be ashamed. Who's using an EMR right now? Okay, so good portion of people here using an EMR. For those of you not using an EMR, is it just because you're afraid it's going to slow you down? Is it that kind of stuff? Because that's what I hear the most. It will slow me down. I will retire before somebody makes me go on an EMR. So raise of hands, is that you're going to slow you down? I hear you. There are ways to use an EMR that won't slow you down, but there's a lot of pieces that go into that. And I think where everybody falls short is a vendor comes in, does a beautiful demo, and you get this impression that that's how it's going to work in your office. And it's not even close to how it's going to work in your office. And so you buy something, and then you're chained to your computer, okay? So that's one of the barriers to getting an EMR. Another barrier is people bought an EMR because they got a demo, and now they're on an EMR that doesn't really work for their office. So we have some clinics that are still on paper charts. We have some clinics that are on oops, let me go back one, that are on paper charts and computers, because they haven't really abandoned the paper. So the staff is using the EMR and the doctor's still in the paper chart, and then they're scanning the charts into the EMR. So hopefully some of the stuff we talk about today will help you get past that barrier. And I say this is my funny picture, but would you really be using these tools if you're a surgeon? Probably not. Yet I'm shocked at how many doctors, and this isn't a negative feeling, it's just trying to understand what goes into this thought process, why you would still run your business. And if anybody was in Dr. session earlier today, we were talking about not learning how to run a business when you're in medical school, because that's not even covered in your curriculum. Why you would trust your hundreds of thousands of dollars business to old technology that doesn't let you know where your money is and make sure that you're collecting all your money and doesn't protect you from liabilities for charting issues and stealing paper charts and things like that. So if you wouldn't do surgery with these, then you probably don't want to be operating in the old way that you have been, okay? So that's my second thing. Then don't do this to your office. If you're one of those providers right now that's charting on paper and everybody else in your office isn't on paper and they're making special workarounds for you, then you really want to think about the extra burden you're putting on your staff and all the failure points that are there that are a liability for you as a provider. Because when things don't get into the chart because there wasn't a clear process, and then you get called into court or whatever, now you've got a problem, or you have an audit done, now you've got a problem, and that's a liability for you, and don't put that liability on yourself. So you've decided you're going to do this, now what? Okay. Choosing the right software. Again, you didn't go to school to be an IT person, so how do you know how to choose the right software? And you get these demos, and they just make it seem so, don't worry, doctor. We have hundreds of doctors just like you, and we know that this is going to work perfectly in your practice as it does in 3,000 other practices. And they do a very slick demo. And very often, as you start to chip away at the demo and start asking them really tough questions, they get lost. They can't answer your questions because they're a scripted demo, right? So how do you weed out what's best for you? First thing I would do is if you're demoing software, you make them do as many demos as you need them to do to make sure that you are comfortable. Get every single person in your office in demos. I tell people all the time, I demo software. I tell people all the time, give me a billing demo so I can show your billers and let them ask me as many questions as they want. I have a group of pediatricians. We did 48 hours of demos before I let them sign a contract. They had already been on an EMR, and it failed them. And I wasn't going to let them fail again. So I said, you have to exhaust me. Doctors, sit down with your demo person and bring your charts to the demo. And let them give you the computer and control the computer if you're doing it over the internet or if you're doing it in person. Let them let you chart your visits. So you can see real time what your data is going to look like and what your comfort level is with clicking things and typing things and all of that. So you want to make sure that it works for you and you don't work for it. That's definitely the key. And then there are different kinds of software. So how do you decide? So there's old school, which is still relevant for a lot of people, client server. You have your own server in your house, in your office, and you have client machines that talk to that server. So you're responsible for that database and all of the software upkeep and all of that on the database. And then there is software as a service, purchased and leased licenses. So if I'm doing software as a service, I'm not paying $25,000 up front for my licenses and all of that stuff. I'm paying a monthly fee. And then there's some free ones. There's software as a service that's free. Practice Fusion, free software, okay? It's got some other issues, and then you got to buy a PM system to do your claims. So the PM system may cost you just as much as buying a fully integrated EMR PM system as a software as a service. So how do you make those decisions? How do you know what to buy, what's right for your office? So we're going to go through a little bit of what the differences are. Purchase licenses. It's like going to the store and buying Microsoft Office for your home computer. You have that Microsoft Office on your computer. You can only install it on your computer. And when you need to upgrade it, you got to go buy another version and upgrade it. Okay? When you buy licenses, typically you either have them on your own server or you, and we'll talk about this in a second, or you pay for somebody to host it for you. So if it's on your own server, you've got a server, and then you've got the client machine, so all your staff and your laptops and all of that stuff, okay? So at that point, you're buying the software, you're paying annual maintenance on the software. No software vendor gives you software and doesn't charge you for upgrades and all of that stuff. Sometimes they'll let you not pay annual maintenance, but you can't get an upgrade until you pay for the upgrade. So annual maintenance is not a way to gouge a doctor, it's a way to keep your software vendor in business so they can continue to pay their developers to continue to upgrade the software. So if they're not charging you for something, they're not going to be in business for very long. Okay. Somebody just told me she's got a great piece of software. It's $250 a month. It's hosted. If she's out of the office, they don't charge her. Everything's all included. It's not a sustainable model. It sounds great. It sounds like it's a great piece of software, but how long is that company going to be in business? They're probably building it so they can sell it to some bigger company who's then going to change that whole model, and you're going to lose the $250 a month and you're going to pay when you're not there. Because you can't keep a business running on that. So if you're buying software, understand that you're going to be buying other software to go with it. So I'm buying an EMR, that is a database. I will have to buy a server. The server will have an operating system, which is expensive at the server level. It's not the same as buying Windows 7, 8, or 10 for your computer. And then I'll have to buy the database engine. So usually it's SQL, SQL, or Oracle, or Unix, or whatever the database engine is. So you have to buy that software. So the server itself, the hardware may cost $5,000 to $8,000, and then you're buying all the other pieces to go on there. So pretty soon you're at $12,000, and then you have to pay somebody to build that server for you, and then you have to maintain that, the life's and all of that. So that's purchasing software. Software as a service. You are basically leasing the software at this point. So I just used the example of Microsoft Office. The old version was you bought it, you can go to Costco and buy it, you go to Best Buy, whatever, you bought it, you installed it on your machine with a disk, which I don't even have a disk drive anymore. I just had to order one because the external one that I had broke, and I don't have a disk drive. But that's how we did it. Now Microsoft Office you get it through Office 365. It's online, you log in, you buy it, you pay an annual fee for it. And when you log in, you download it onto your computer, and there it is. Same thing with EMR and other things that you use in your office. So email is software as a service. Office software as a service. Your EMR, so Practice Fusion that we talked about, is free, but it's software as a service, meaning somebody else is providing that service for you. So what are the options for that? Everybody talks about what's in the cloud. Well, the cloud is kind of a nebulous description of the other place, meaning not your office. So some of the options for what's in the cloud are web-based solutions. So web-based meaning a web page written in the HTML language. Okay, so Google is HTML web-based page. So Practice Fusion, earlier this morning, the doctor from Montana said he loves Athena, and that's the product he uses. And I'm not here to bash any products. The problem with web-based programs is that you typically cannot customize them to your practice. They are what they are because they're hosted by them on their servers in their language in the way that they want them to be presented to you. Now, there are certain customizations that everybody can do that you can create pick lists and things like that. But how the program works and how it's delivered to you is controlled by what's available in HTML. So if you're a biller and you like to have 17 windows open at a time, which that's a traditional biller scenario because they have demographics open in several different claims at a time, and then they're taking phone calls. It's almost impossible to do in a web-based piece of software. So don't make your software decision based on what works for the doctor. You have to make the decision on what works for the whole office staff because they're keeping you in business. It's great that you want to treat patients, but if you can't collect the money because your biller is being strangled by the software that you've given her because you like the EMR, but the PM is very, very weak, then you'll be in that position. So not saying don't pick a web-based software, just understand what the constraints are involved in a web-based software. ASP hosted. ASP stands for Application Service Provider. So in an ASP hosted environment, you can still own the licenses, or you can lease the licenses from the provider, okay? So whoever your vendor is. And that typically means that you're getting the full product as if it was in your office. It's not a web-based product, but you're accessing it via the web. Okay, so that's the difference between a web-based product and a cloud-hosted product, okay? Meaning you're just going through the cloud to get to it. It doesn't mean that it's in the cloud. It's still on somebody's server somewhere. Just somebody else is managing the server. Well, the benefits for that are, now you don't have to buy all that software to run your server. You don't have the liability. We're going to get into data breach in a minute, but you don't have the liabilities inherent with having your own server in-house with all that patient information, all that PHI on your machine in your office. Because now you got to do all this data breach protection of that machine, and you really need to know about that, and we'll talk about that in a minute. So why would I choose the difference between ASP or web-based? Well, again, it goes back to what's the functionality of the product. Another key decision maker here in Hawaii is our cost of internet at the commercial level. I don't understand why it's this way, because it's not this way in the rest of the world. I have Hawaiian Telecom at home. My download speed's 100, my upload speed's 50, and I pay $100 and whatever a month. When I try and get that for my doctors, it's like $2,000 a month for a solo practitioner to get the 150 combination. Most of you, and depending on what your connection is, what I'm seeing the average of my doctors is 20 down and 6 up. Well, it's functional, but when you start adding 15 users in your office or 5 users in your office, really depends. I have one doctor here, he's not here today. He's 1 down and 1 up, a little bit less than 1 up. And he's an ASP client. So their challenge is they can't scan in the office. They can't. They can't scan documents and link them because they're trying to link images across the internet. They can't do it because they don't have enough bandwidth to do it. So when you're looking at web-based versus ASP, you want to take into consideration what your bandwidth is and the cost of your bandwidth. Whether you're Oceanic, Hawaiian Telecom, whatever. Some of you are in hospital buildings, so you're actually getting your internet through Queens or Palimomi or Kapiolani or whatever. So you may have constraints there as well. But those are the issues between web-based and ASP hosted. So you've decided you want software. You found the vendor that you like. You made the decision on how you're going to do it. In-house, web-based, hosted, whatever. And now what? The next step is implementation, training, and upgrades. Okay, so probably the first thing I hear from providers, especially in Hawaii, is we didn't pay anybody to come out on site to train us because it was just too expensive. You didn't go to medical school and not get trained to treat patients, so why would you trust your business, that is your livelihood, to the software that's running your business and not get the required training to do it? And I'm not even talking about just the doctors getting trained to chart. You could type anywhere. You can drag it into anything. You can dictate and have somebody put it in. You can use a scribe. So I'm not even talking about at the provider level, but I tell you, this is where everybody fails. The very first point of failure for software is not enough training. And the software life cycle in medical practices before we went to EMR was 2 to 5 years for practice management systems. And now we're closer to 2 years with EMR systems. And the biggest reason why people leave software is they think the software doesn't work. But when we really sit down as consultants with our customers and look at what they're doing, and we talk to their vendor on their behalf, 90% of the time is because they haven't spent any money or sufficient money on training. And you're doing CMEs, Your staff's doing whatever they need to do to learn their job, and a lot of times, you don't have certified coders, you just have billers that you've trained that used to work at the front desk, and now you've trained them to do billing in your office, and so they really don't have the education behind what they're doing. They got tribal knowledge from the person before them. So they're doing workarounds, or somebody said today, called it invented processes in their EMRs. Workaround's like a 4-letter word in my world, because it means that you really don't know how to do it. You just kind of figured out a way to hack your way through the system. And really what we want you as a vendor, we want you to be the most proficient user. EMR implementation should take 12 to 24 weeks, depending on the size of your practice and the level of your specialty. Not, we can get you up in a week or two and we'll do it all over the web. I cringe when I hear that that's how people went live on their system, because I know that you didn't get what you needed to be good at what you're doing, okay? So invest in the training. I get it. It's expensive to fly people to Hawaii. It really is. Talk to your vendor about ways to cut costs on that. We're going to pay for you to fly out to Hawaii from Florida, Texas, Atlanta. Those are some of the big places where the software comes from. So we know that that's already going to cost us $1,000 to fly them out here. Is there a way that we can get a break on the daily rate, a training rate? Because your employee's going to probably tack on a few days of vacation while they're here. So can we get some breaks on that? You can negotiate all of this. And the number one point of negotiation in your EMR purchase is the training and implementation, because that's not a hard cost. For the vendor, the margin on software is very, very small. It's not a big margin. So really, they're making their money on, and I can say this as a vendor and as a consultant who helps customers, the money's made on the implementation. Now, for my group, the money's lost on implementation because we over-implement everybody. We quote you 7 days, we're there for 3 weeks. I'll be there until my kids graduate from college and have kids, because I just want you to be successful. So you want to negotiate that with your vendor. Don't skimp on training, okay? Say yes to upgrades. I can't tell you how many doctors say to me, yeah, we're still on version. I have a client that just told me their server is version 2000. Okay, right there is a HIPAA violation, because nobody's patching version 2000 with security patches. And the HIPAA rule states that you need to keep your systems current and patched with security patches. So if you're on old software, don't pull out your flip phone and say to me, but this still works, which I can't even tell you how many times that happens. But look, my phone still works, so my computer's still working. Why do I need to replace it? You need to replace it because it needs to be current, okay? So when your vendor says we have an upgrade and the upgrade is going, sometimes you have to pay for upgrades depending on who your software vendor is, right? So people, I don't want to pay for the upgrade. Or I don't want to pay my IT company to do the upgrade for me, or whatever the scenario is, the reason, the barrier to upgrade. Upgrades have a lot of value. They're fixing bugs that are in the software. Whether you know it or not, Microsoft is upgrading you every week. They're patching you every week. If your computer's rebooting on Wednesday, it's because the patches came out at 3 a.m. on Wednesday, and your computer didn't get changed in the settings to not patch you automatically, because that's how they ship them. Then that's why your computer's rebooting on Wednesday. I can't tell you how many times we get phone calls going, my computer keeps shutting down, and then we start tracking the calls, and it's like, 9:30 on Wednesdays, their computer shuts down. The patches. If you're a Mac person, my phone, I get an iOS update that says it's ready to upgrade, right? They're fixing bugs. They're fixing security leaks. Like, that's the main reason to upgrade. And then they're usually giving you enhancements. And why wouldn't you want the enhancements? Just because it's working doesn't mean it's working well. So take the enhancements that they're giving you, okay? And then train. Okay, so you got an upgrade. You got new features and functionality. Everybody gives you release notes when they upgrade. Even my iPhone gives me a link to the release notes and tells me what's there. Now, I live in a family of geeks. I have a husband who's an engineer. I have a son who's an engineer. So I just basically say, hey, what changed on my iPhone with the iOS whatever upgrade that I just did? Anything you think I need to know? And then they tell me. Or I go to YouTube and I look up the 10 new tricks in iPhone and watch somebody's YouTube video, because there's 10,000 people out there making these videos. YouTube's your friend, by the way. In technology, when you don't know how to do something, YouTube it. Google and YouTube, I don't know how I worked 20 years ago. I'm not even sure how we did this without Google and YouTube. Somebody's already figured it out, and they'll walk you through it, okay? Your vendor gives you training with upgrades. Take the training. Don't be a hack. What's sad to me is that you make this huge investment in your software. I go into your office 5 years later, and you're at 25% capacity in the software because you've not done any of the training or the ongoing educational opportunities that are afforded you through your vendor. Your vendor does a conference every year. Pretty much every EMR vendor does a conference somewhere. Send somebody from your office to the conference and have them come back and train everybody else. It's a community. So I don't know, most of you look like that you've all been here for a while. There's an organization here, it's changed names, but there's an organization called the Baby Hui. Now it's called the Family Hui. It was started by the State Department of Health, and it was to help parents of children birth to 3. It's a child abuse prevention program, in essence. But because we don't live in multi-generational, it's a little bit different in Hawaii, but a lot of people that live in Hawaii moved here from somewhere else. I'm a transplant from 1983, but I'm still a transplant. We don't have a community around us to help us know how to raise our children. You know, it used to be that your mom and your auntie and your sister and everybody lived in the same house or in the same block or in the same town. And so they told you how to use the system. You have the same community in your software community, right? Your vendor doesn't just have you as a client. So going to the vendor conference is where you learn from other people who are in your specialty how they're using the system. If your vendor does user groups locally, go to those, do their online webinars, look to see if they have forums online, and start self-training yourself and talking to other people who use the system. So build a Hui around your software to help support your practice. Okay, so these are all assets. If you go to sell your business, your software licenses, your hardware, all of that's listed as an asset. You're paying property taxes on all of these things. So it behooves you to manage them. But how do you know what to do? So I hear a lot from providers that, well, I set my budget this year because I went on EMR. So I've got these dollars for the EMR, and I've got these dollars for the new computers that I bought, and I've got these dollars for my IT consulting to get everything in my training and all of that. So this year I'm going to spend $25,000. I'm a solo practitioner. It's going to cost me $25,000 to get up and running on my EMR. Because I had to buy computers and all of that stuff. Okay, so is that the only time you're going to spend money in a big way besides your monthly stuff or your annual thing? What about those computers? How long can you use them for? What is the life cycle of a computer? So go back to the HIPAA statement that I made a few minutes ago. You have to stay current. So if anybody's using XP in your office, Windows XP, you are in HIPAA violation. And the only way that you're excluded from HIPAA, and frankly I didn't know this till a Maui doctor schooled me on this, because he is not HIPAA compliant, because he doesn't file his claims electronically. As soon as you file a claim electronically, you are bound by HIPAA. If you decide to opt out, you can't file a claim electronically, okay? So I'm guessing most of you are filing claims to Medicare or to HMSA, and they, HMSA prefers that you file them electronically. Medicare mandates that you file them electronically. You need to look at the life cycle and budget that in your office, right? So I know that I bought all these computers this month to go live on our EMR. I should be putting in my projections for my budget 3 years from now that I'm going to have to replace those computers, okay? Or upgrade the operating system. Oftentimes, like those of you who have iPhones in particular, they make it so that in 2 years when the big upgrade comes out, you can't upgrade your iPhone because it doesn't have whatever chip in it that you need to make that upgrade happen, so you got to go buy a new iPhone. Again, there's a reason why they do that. They time all of that so that it is synchronized that way. So you've got all these computers in your office, and now doctors are coming in and they're saying, well, I have my iPhone and my vendor offers a mobile app, so I'm looking at that on my iPhone, and I want to use a Mac, and I don't want to use the computers in the office, so I'm going to bring my own device, BYOD, okay? Started to become the norm a few years ago, is really, really becoming the norm because the millennials are saying, I don't want to use the garbage that you buy in the office. I want to use my laptop that I also use for gaming, and it's got a much faster chip in it, and it's got better graphics and all that stuff. I don't want to use what you're buying, okay? So are you going to allow BYOD in your office? Well, you're probably already doing it without even realizing it. Most people think, well, we're talking about computers. Well, we're also talking about phones and tablets. Whatever anybody's accessing your data on. So I look at my email on my phone, that's BYOD, okay? I look at my EMR on my home computer, it's BYOD. I'm in a web-based EMR, I can get to it from anywhere. I'm not using an organizational bot system, it's BYOD, okay? Do you have BYOD policies in place? Now you probably can't see this because we're all far away, but Dilbert's saying, my only hope for productivity is to smuggle in my home laptop. That's how the younger people look at this anyway, because they look at, you put them in a computer and it's slow and they're used to it. Nobody's got an attention span anymore. Everybody wants everything instantly. And if you watch these kids who are gamers type, and I can say kids because my kids are 30 and they're kids, and you watch them type. I used to think I was a fast typist, and I look at my kids, I'm like, where did you learn to type 300 words a minute? Well, when you're gaming and you're going to get killed, you have to type 300 words a minute because you're going to be dead if you don't in the game. So do you have policies in place? You have to have policies in place to be compliant for meaningful use and HIPAA. So I can tell you this is probably the biggest hole in every clinic. Many of my clinics don't even have employee handbooks, so let's take that back 12 notches. Do you have policies for how your equipment is being used? So let me give you an example. This is a real life story. Employee checking email at home, got injured in the home, and had a valid workers' comp case because she was walking and looking at her phone and fell. And what she was looking at was her email, and they were able to time and date stamp her reply on the email to the time that she fell, and she had a valid workers' comp case. So, I know that this sounds far-fetched and crazy, and everybody thinks it'll never happen to them. That was one of my clients. It happened to them, okay? So, if your employees have access to email on their computer, they're BYOD. You need a policy. And your providers, you're at your kids' whatever practice, football, baseball, fill in the blanks, and you're charting in the mobile app for your EMR. Nothing wrong with that. Do you have a lock code on your phone or your tablet? I literally had a doctor slide me his phone the other day, and he said, can you set me up? And I go, give me your code. And he goes, what code? I go, what's the code that locks your phone? He goes, just swipe. So I got the bucket out and threw up into it, and then I said to him, you can't do this. Let's put a code in right now, because you're accessing all this information here. And he had an EMR that allowed him to sync to his Outlook. And in the EMR, he had the option to show patient names or not, and it says right in the EMR, if you are showing patient PHI on your phone, make sure you have a swipe code a lock code before you integrate this to your phone. So I made him do it. Okay, now I need my old lady glasses. 200 million, this is this year, this was actually last year, 200 million employees bring their own device to work. And that's not just in healthcare, that's just in general. 50% of companies who allow BYOD have had a security breach. Nearly half the number of millennials, the 20-somethings, who will make up the workforce in the next 8 years. 182 billion mobile apps will be downloaded in 2015. That's crazy. 50%, for an old girl like me, that's crazy. 50% of businesses, mobile devices, will be personally owned. So I have 5 employees. I bought them all cell phones. They don't use my cell phone. They forward it to their phone. And they keep it in a drawer. I didn't actually know that until recently. So, and I have a policy that states you can't do that, but they all do it. They're 20-somethings. They don't want to carry 2 phones. And I got them not the coolest, greatest phone that they wanted. They wanted the big phablet phone. And I got them all iPhones, but it wasn't the 6S, the 6 Plus, whatever the bigger one is. 1/3 of those employees admit to breaking or would break policy, corporate policy, to use their own personal devices, like my employees. Need to admit it, okay? No shame, it's happening to all of us, okay? So let's talk about those billions of mobile apps. So you got BYOD, people have their tablets, their phones, and then they're downloading all these apps. And they're on Facebook on the same machine that they're accessing your EMR. And they click on a link in Facebook, and the link says, oh, we want to copy all your contacts from this, and we want access to whatever on your phone. They've just opened a gaping hole in their phone, possibly to the data that they're using on your phone, on their phone. Okay? So this goes back to policies. Do you have policies in place that if they're going to use their phone or their tablet or their own computer, what are they allowed to do when they do that? Okay? Are they allowed to download things? Are they allowed to access other websites that say, by accessing this other website, you're going to do this? I have access to all my employees' computers, and I do random spot checks because my work staff mostly works from home. So in order to be compliant with my data breach insurance policy, which we'll get to in a second, I need to confirm that they're not doing any of these things. So I have remote software set up on all their computers, and I remote in. I say to them, leave your computers on. I'll be remoting in at some point in the next week. And I look to see what they have stored on their computers. They all use laptops, so they're not allowed to store any PHI on their laptops because the laptop can be stolen. So we have an office here, and we have an office in Portland, Oregon. And the big health plan in Portland, Oregon, one of the big health plans is Providence Health Plan. They own hospitals and their health plan. They're the big poster child for data breach in Oregon and Washington. So they're Oregon, Washington, California, Idaho. They had an employee who was in their research division, but had all this data on his laptop. Left it in the car, went into a bar, whatever, shopping center, wherever he went, but he left his laptop in the car. Now, we all do that, right? You're going home from work, you make a stop. Do you really consider bringing your laptop into every place you go when you stop? Car got broken into, laptop got stolen. 2 million people's PHI on that laptop. Here's the cost of that. The initial fine is $250,000 just for being notified, the OIG being notified that you had a breach. Then it's like $250 per record. So if you can prove that your breach was 15 records, then you're going to pay the $250 per record. If you can't prove what records were breached, you're paying for every record in your system. That's how that works. So you want to make sure that if you're using mobile apps and if you're giving people BYOD permission, that you have very strict policies, that they're enforced, and that they're audited. Because you have to protect your practice. And I hear a whole lot of people calling their retirement people. So let's get back to what makes this easier for you. Because really this goes to you. BYOD is going to be more acceptance in your office. People are going to do things that they're supposed to do. You just need to have policies and procedures around that. Let's talk about the patients and getting them engaged in your office and doing some of the work for you. Every EMR system that's certified to do meaningful use, which should be only EMR systems that are on the market at this point, have patient portals because that's required by meaningful use. So how many of you don't have a patient portal yet? How many of you think you don't need a patient portal because your patients are senior citizens and aren't going to use the portal, right? Or that you have a poor socioeconomic group and they're not going to use the portal or whatever. Pick an excuse, right? But there are a lot of people say, I'm a urologist. My patients are all 70 plus. They're not going to use the portal. Today's patients are using the portal, okay? 63% of adult cell phone owners want to access their record on their cell phone. 69% track health indicators like weight, diet, exercise. Everybody's wearing a Fitbit. Or using their iPhone or their Samsung or their whatever that tells them how many steps they took today, what their heart rate was, their average sitting heart rate, their average moving heart rate, all of that stuff. 35% of U.S. adults have gone online to figure out a medical condition. Dr. WebMD, right? How many of your patients come in and say, Doctor, I Googled this? The Mayo Clinic said, I have a brain tumor because I've had this headache for 3 days behind my left eye. Okay? I want an MRI, a CT, and a PET scan. And I'm not leaving till you sign me up for all of those things because I've been researching this since 3 o'clock this morning. Okay? I'm guilty. I sent a thing to my doctor and I said, I have restless legs, and at 3 o'clock this morning I had nothing better to do but look it up. And they recommended these nutrient things, these pills to take, vitamins. What do you think about that? She said, well, could work, but there's also a prescription for that. I go, all right, I'll try this first. And if it doesn't work, I'll come see you next month and we'll do it. So everybody's guilty of it. But Dr. Google and Dr. WebMD are interfering with your ability to practice because your patients are going there. Patient portal, let me back up a second. Patient portal, my 80-year-old mother lives with me and has lived with me for the last 10 years, and she's got chronic, severe illness. So I take her to all her doctor's appointments. I don't go to doctors that don't have portals because I work 70 hours a week. I don't have time to fill out reams of paperwork to bring into the doctor's office, then to be interviewed by somebody to go over every one of those same questions that I just filled out the reams of paperwork on. I want a portal that I can go in for her. First of all, you get better data. When your patients have a portal, they actually give you better answers than they would if they were sitting there for 15 minutes in your lobby trying to figure out what grandpa died of, okay? So when I sit with my mother, and it's a great thing to do, I'm interviewing her about her family's history. And I'm putting it in the portal. I'm doing a review of systems, her past medical history, her allergies, her social history, all of that stuff for you. So that is all you have to do is click a button and download it into your record. And then you could just pick up on the pertinent things like, well, Marilyn, I see you quit smoking 30 years ago. How much did you smoke before you quit? Great, now you just met that meaningful use thing, you're moving on. You don't have to go over her entire thing. She likes to tell a whole story about her 450 surgeries she's had. I just go in there and say many orthopedic surgeries, moving on. And then the eye doctor doesn't really care. He just sees that she had orthopedic surgeries. Otherwise, she would have dragged him down that path of her surgery history, sitting in the room with him. Because they ask her, what kind of surgeries have you had? And she starts at age 4. She's 80. Did I say that? So you want to get your patients engaged and make them do some of the work for you, and they'll give you better information. All right, this is a real problem in Hawaii. This is actually one of my clients. I'm going to tell you a quick story about this guy because he's my favorite client in the world. He called me, he was 68 years old when he called me, and he said, I want to buy EMR from you. My other colleagues really like you and they like your EMR. And I said, I'm not selling you an EMR. You're 68 years old. Why would I sell you an EMR? First of all, why are you still in practice? And why would you put yourself through this? I tried to talk him out of it. I begged him not to let me sell him EMR. He's our best, most compliant, he's 73 now. He's our most compliant EMR user of all the doctors we support. He's like, I like a good medical record. I want to be current. And if I decide to sell my practice when I retire, I want all the pieces in place and make it easier for the person who takes over my practice. And he had a website, but it was something that his kid did in high school, and it was a gray screen with his picture and a big long text box that said who he was. And so he needed patient portal, and he goes, it's a good time to redo the website. If you go out to my booth out there, you'll see the table that I have out there. We partnered with this company that did his website. And I'm not doing this to plug, I'm doing this to tell you that websites don't need to cost you $8,000. If you're paying thousands of dollars for a website, you're using the wrong web developer. Because you're a doctor's office. They need to know who you are, how to find you, and where the button is for your portal. This is Dr. Saito's website in IAEA. It's one page. Notice there's no tabs across the top. There's nothing. It's just who we are, what are the doctors in our practice, where's our location, what our office hours are, and the big old patient portal button in the middle. Patients don't get lost on this website. So we went looking for web developers that would help our practices. When I moved back home 3 years ago, I started looking up some of my doctors online, blah, 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 and I couldn't find a website for anybody. What's really sad is a lot of you, it brings me to Yellow Pages online. If you are taking ads in the Yellow Pages, stop now. Nobody uses the Yellow Pages except for monitor stands to put your monitor on. Nobody uses the phone book anymore. They just threw mine over the thing the other day. I have a gated front yard, so they threw it in a bag over my yard the other day. And I take the bag and throw it in the garbage, and I throw the book in the recycling bin, and I'm done. I never even look at it. So many of you, when I go to search for the doctors in Hawaii, like I need to contact somebody, the very first thing that comes up in Google is their Yellow Pages ad and the link to the online Yellow Pages. The most expensive advertising you can do and the least technology-driven thing you can do is Yellow Pages. Okay, so get a website. This website here, $500. Branding and everything. So it's called branding in a box. They give you the brand, they do the whole yard, it's $500. Doctor that spent $8,000 on a website was a big old Word document with the doctor's picture. Okay? So you have the software. Now you've got partners. We're here at the HHIE Summit, right? So interfaces and integration and interoperability. Okay, so I started consulting in 2000. By 2003, we were all going to be connected. I've been going to these interoperability, I can't even say it quickly, conferences since the early 2000s, and we were going to be all connected by 2003, 2005 at the latest. And there were health information exchanges that came up and went down, and came up and went down. And it just never happened. Really, the government has forced it to happen. So you have an EMR. Your faxes are still coming in on paper, and then somebody's scanning them into your EMR. Makes me cringe, because that's way too much work for the person who's doing the scanning and linking. Your faxes should be coming in either to a fax server, or I'm even more frugal than that. If you have a fax machine in your office, it's probably networked. You can drop those faxes to a network folder, and then the person just needs to move them into your EMR. Stop printing faxes, please. But then you're still getting lab results on paper. Sometimes the hospital faxes them and sends them in the mail to you, okay? You're ordering labs on paper. You're doing all of this stuff still on paper, and you have this great EMR tool. Any EMR that can't interface with everything else in the world is not a current EMR and something you should be looking at getting rid of, okay? So, how do interfaces work? Until the exchanges really get up and flowing between everybody, and you have direct connect interfaces. So you send people to DLS, Clinical Labs Hawaii, you have an interface with each one of those separate interfaces, okay? If you see patients in the hospital, you probably have an interface with the hospital, and you're pulling down records and discharge summaries and all of that from the hospital. Currently, if you're doing meaningful use, starting this year, you need to be able to interface with other doctors' offices' EMRs. It's called direct mail through a HISP, which I think is a funny word. HHIE is getting registered to be a HISP, but right now your EMR should have a HISP vendor that you could send a CCDA from so I'm primary care, I'm referring somebody out to orthopedic surgery, I need to send those records. I'm not faxing them anymore. I'm going to send them from my EMR to their EMR. Fax is pretty insecure, FYI. There's a Canadian, Canada doesn't have HIPAA. There's a great graphic. You can Google this, you'll find it. There's a guy who owns a car garage, a maintenance garage, and his fax number is 1 digit off from some doctor's office. And the picture is this guy sitting there in his greasy clothes with a stack of medical faxes that he gets every month So even though HIPAA says faxing is secure, it's only as secure as you knowing that it made it to the right phone number, right? So every month he gets them, and it's not good. So you want to do interfaces between your system and the other systems. HHIE is coming up with the community record where everybody's going to be dropping their information to the HHIE, and you'll be able to see it in your system. Okay? You'll just have a link from your system to the community record. You can pull down what you want, but you can leave stuff up there if you don't want to pull it down, which is key, because you don't want your databases growing exponentially every year and having to pay for space and all of that kind of stuff. Okay? So that's the HHIE single point of interface. So right now, everybody's got lots of interfaces. And sometimes your vendor charges you to build those interfaces because it costs them money. They have to have developers, and they go, well, you've already built interfaces. Even though I build interfaces with the same hospital over and over and over again, no two clinics are the same. And how they send their information is not the same, and how they chart is not the same. So every interface, even though the building blocks are the same, has to be customized and tested by every clinic. I always find it funny whenever we are with doctors that are going on EMR and say they're in a group of 2 or more, they say, we're going to standardize. We're all going to chart the same way. I go, okay, well, that's a nice fairy, and I believe in unicorns. That's not going to happen. Because the minute you get that EMR in there, you're going, I don't like what he said there. I don't like how he said that statement. I don't like how those click buttons are laid out. So that doesn't work. So you want a single point of interface, and HHIE is pretty darn close to having this universal for everybody. We need to keep supporting them so that they can stay in business so that that will happen, okay? Good group of people at HHIE. They have really good support from the hospital systems, because the hospitals don't want 50 million EMR interfaces either. They want one interface through Medicity, who's one of the vendors that's out there, who's a big national interface company, who then interfaces with HHIE, okay? As much as everybody hates the government and ARA and the standardization, the benefits of the standardization for you at a practice level is it's forced your vendors to standardize their data sets. So now your CCDA and my CCDA and her CCDA all look exactly the same. Okay, and that's important. Okay, so I kind of sort of started talking about this a little while ago. Okay. Speed this up. Data breach security. I'm not here to make you want to lose sleep or crawl under a rock or quit your job and retire. The most neglected part of this whole picture is data breach. Target, Home Depot, big companies, huge data teams, they got breached. Okay. Providence Health, big data breach. Anthem, huge breach. I've been involved in so many of those breaches that all of those companies have to give you 3 years of credit monitoring. So I'm being monitored by Target, by Home Depot, which, by the way, I got my credit card breached by Home Depot and used. My bank called me because somebody in Michigan was buying a ton of stuff, and they called me and said, don't you live in Hawaii? Have you been at this store lately? Because you just bought like $9,000 worth of stuff in the last 12 hours. I'm like, nope. And they were able to stop it and give me a new card and retro all the charges back. I was a Providence patient. So all of these things, I'm being monitored by so many. I'll never have to buy LifeLock or any of those systems because I've been caught in so many data breaches. Everybody else is monitoring my data for me. Of course, I can't open a credit card, buy a car, or anything without having all those companies call me to confirm that that's me doing that activity. It's a small price to pay. So, data breach protects your data. Your data is the lifeblood of your business. It protects your patients, thank you. And it protects your business because a data breach will bring you down. Now, data breaches aren't just necessarily somebody hacking into your system. Most data breaches are internal mistakes. So you print out of your system the clinical summary as the person's walking out the door, their discharge summary, but you hand it to the wrong patient. It's a data breach because it had the other patient's PHI on it. It's a data breach, okay? So it's not just the hackers from the outside. On the black market, medical records go for typically $10 per patient, per record. Trust me when I tell you that people are hitting up your employees all the time, sending them text messages, whatever. Hey, I see you work in a clinic. Want to make some money? So your employees innocently go, sure, what's that? Good people make bad decisions based on situations in their life. Embezzlement, whole another story, and stealing medical records happens all the time. People are selling your patient lists to the black market so that they can make phony patients. Don't have enough time. Really good story. You want to hear my long story, come talk to me outside. About a customer of mine who had a patient who they treated, and after he died, the estate figured out that the guy that died wasn't really the guy whose name it was. So, okay. So how do you protect your PHI? Do you have a plan? Again, we're back to the plan, policies, and procedures. Make a plan, document it, test it. Having a plan in a closet or in a binder does not make it a successful plan. You have to test it. There are plenty of companies out there that will help you test your plans. Lee Castanguy, who used to work for the HHIE and is a HIPAA consultant now, who lives here and is walking around today, can help you make a data breach plan. There's plenty of people doing this, okay? Write your processes down and assign people roles and make actions, just like a fire drill. You've identified a breach happened. What do you do to shut it down and make sure that you take all the necessary steps? Because the government says, oh, you did due diligence. It was an honest mistake. We're not going to charge you $10 gazillion for that breach. We want to know what your remediation plan was. What did you do in your war room when you figured out it happened? Show us your documentation that shows what you did, okay? How do you respond to a breach? It is going to happen in your office. It probably has already happened. I heard one this morning just being here, okay? It's going to happen. It happened on paper. It just was not as easy to trace on paper, okay? If you don't already have it, call your insurance broker and make sure you have data breach coverage. It's a rider on your commercial insurance plan, your liability insurance, right? So you insure everything else that's in your office. Insure for data breach and insure for employee errors. It's not that expensive. Hundreds of dollars a year. Not that bad considering what this can do to your practice, okay? So we've talked about all these horrible things that can happen to your practice, and I don't mean to be the black cloud over your practice, but now what do you do? How do you pull it all together? Consultant isn't a bad word, and it used to be a bad word back in the day. I mean, when people said to me, you should be a consultant, I would go, no, why? Because if you can't get a job, you teach, and if you can't teach, you consult. That was always the mantra when I went to school. Nowadays, you can't do this on your own. You need people to tell you, and that doesn't mean your college roommate's son who's going to college and knows a little bit about whatever. You need people who are qualified, certified, whatever, to tell you what to do. Have network support. Can't even tell you how many of you guys are pieced together here. It's just killing me when I walk into a practice and everybody knows the same password. Don't have to hang your head in shame. Everybody's doing it. Stop it, right? Get the right network people who will help you enforce the rules, okay? Have vendors that support their software. If you don't have a vendor that does good software support, you're with the wrong vendor. They should make your success their goal. I mean, just from a business standpoint, wouldn't I want all my customers to stay in practice so that I can sustain my business? I mean, it just makes sense to me. A lot of people are in it for the quick money, and then they want to move on. And then you want a single point of contact, one throat to choke. Not a very good saying, but it really does make sense. You're in the middle of doing something, and all of a sudden, everything stops working. You don't know if it's your internet. You don't know if it's your software. You don't know if it's your hardware, the switch, the router, the whatever. Why would you be calling 5 different organizations to figure out if there's problems so that they can all then point the finger at each other, right? You want to make sure that one of these people here, one of these organizations is going to be your single point of contact, and they're going to contact everybody else and come back to you and tell you what's going on and help you get it fixed. Okay? And finally, embrace your technology. It's here. Unless you're just going to stay on paper and retire in the next couple of years, you need to embrace it, because fighting it isn't going to make it any easier for you. It is what it is. Figure out what's going to work for your office. Figure out what's sustainable in your office, and then get proficient at it, get efficient with it, and embrace it. Because fighting it doesn't make it go away. It just doesn't. So the first guy had his head down. This is the guy I want you to be when I come into your office. Thumbs up, right? Don't necessarily have to love your technology, but you feel like it's working for you and you're not working for it. Okay? So we're moving on to questions and answers. I've been pretty quiet. So does anybody have any questions? Oh, you're going to make my job easy. Can you bring her the microphone? Oh, can you come up? Oh, sorry, I didn't even notice that. Can you come up to the microphone? That's a much smarter idea.
And then, can you talk more about the email, the work injury?
Right. So,
I don't know if I understood that.
So the work injury was she's working from home, reading her email in the evening. So she got off work at 5 o'clock, but she has her work email downloading on her cell phone. Okay. So she replied to an email. We've all seen it. People are walking and not looking at what they're doing, and she tripped over something. And she broke her arm because she couldn't stop her fall because she was protecting her $600 cell phone. It's probably a little bit of an embellishment, but that's pretty much the story. Because she was working, she filed a workers' comp claim. It went to arbitration. And she won because she was working. So that employer had to make a policy that nobody is allowed to work after 5 o'clock on their cell phones or other devices, blah, 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 unless prior authorized. This is actually a big discussion internationally. There are laws in countries like England where you're not allowed to work after your cutoff work time. You're not allowed to have access. So the employer actually can shut off the email after hours so that it doesn't download. So governments are getting involved in mandating and regulating this to protect the employers. Okay, and then CCDA is continuity of care document. So it's the stuff that you fax to the other offices when you're referring your patients there, and the stuff they fax back to you after they've seen your patient, right? So currently, you fax back and forth. In meaningful use, starting this year, you need to send that, a certain percentage of those, from your EMR to their EMR. And so the government came up with a standardized format, standardized language, so it goes out in XML format from your system, gets converted, uploaded, so you get a direct mail email address for the doctor that you're sending it to, and it's embedded in your system. So you know how you have your referring providers set up, or refer to providers set up in your system, and that's where you get their fax number from and all of that stuff, or their address when you're going to mail something to them. Now, when you say, I want to send this to Dr. Saito at IAEA, it sees that, oh, his direct email address for CCDAs is X, because there's a field for that, and it sends it to him that way. And they work really well, because what happens is when they come into your system, they come in as a specific attachment type. So there's a new category in your attachments that are CCDAs, and you can see this one came from Saito's office, this one came from Matsumura's office, this one came from McGovern's office, whatever. You can see where all of the documents are coming from and what came in those documents. And there's a certain amount of latitude that you have to setting up what goes out in your CCDA. So you may have confidential fields in your system, and so you don't want the confidential stuff going out. You don't want the behavioral health stuff going out. Your primary care and your patient said that they just had, they're hearing voices or whatever, and you don't want that going out to the ear, nose, and throat doctor you're sending them to. You could segregate that stuff, and there's all these set up in your system. Did that answer your question?
A sort of open-ended question. Could you speak briefly to the state-of-the-art in encryption technology if you absolutely must have PHI outside the shop?
Yeah, so 128-bit encryption is what HIPAA states. 256-bit encryption is government-level, DoD-level encryption. Most stuff that we're doing in these interfaces is 256-bit encryption. And basically what that does is it compresses the data and it de-identifies it to a certain extent so that it's just bits and bytes, and it's not until it gets to the other side that it becomes normalized again and you can see it. So for instance, interfaces are written in what's called HL7, Health Language 7. Okay, so I'm sending a test request from my system for a CBC. On my system, it looks like a CBC. Then it goes in the HL7 and it starts parsing it out in all these different fields. So unless you're in a system, you can't put that back together easily and understand what happened because they hide all the data. And then when it gets to the lab, CLH opens it and it's a CBC again. Okay? So the CCDAs do the same thing. They encrypt and de-identify when they go through the HISP. When you get set up with your HISP for your direct mail, you're going to be shocked if you haven't done it yet at the level of security you have to go through to set it up. Okay? So you have to fill out all this paperwork. You have to have it notarized. You have to give them all your personal information because they have to be sure that you are the person who says they have access to this data. So this is the government's way of protecting it from Joe Blow, who opens up a shop down the street and calls himself a doctor and he's doing Medicare fraud or whatever, to keep him from getting patient information from other doctors. You go get that paperwork notarized, the government, the HISP organization is actually going to call the notary. First time in my life I have ever had anybody call the notary to confirm. And so you need to tell your notary they need to take the call. We've had so many doctors not get their HISP certification done because the notary didn't take the call because they went to their bank and the bank notary didn't know who that caller was and didn't want to give out that information. So we literally, for our customers, made a little script for them to take with their paperwork to the bank that says, "Dear notary, here's how this is going to work. Please take the call or this will be for naught." Right? So speaking of encryption, just a pet peeve of mine, email. If you do not have encrypted email, stop using it in your office to talk to each other. Your EMR probably has a messaging system anyway, so use that. But I literally will have a biller say, "Well, she's sitting right next to me, I'm sending it to her," but they use Gmail. Well, no, you're not just sending it to the chair next to you, you're sending it up to the web, to the Google servers. And then Google's storing it on their servers. It's not HIPAA compliant. And then they're sending it, it's going through 4 different points of web spots to get to you, 4 different hops to get from that chair to that chair. Yeah, it was instantaneous because it's fast, but it's not secure. So unless you're on your own Exchange server in your office, meaning it's not hosted by somebody else and you have your own server that hosts your email in your office, do not send inter-office email, except to say the company picnic is on this day, blah, blah, blah. But not Mrs. So-and-so got a bill and she doesn't like the charges and da-da-da-da-da. You've just violated HIPAA. It's a data breach. So your encryption, when you're on these web-based, you see the little lock on a website, and then it's like HTTPS. That's an encrypted website. If it's HTTP, it's not encrypted. Okay? So you should have passwords. Okay, one thing about the passwords. See, you could leave me up here forever and I'd go on and on and on. I could pretty much tell you most people's passwords, especially office users, by sitting at their desk and looking at their pictures. I know that their kid's 4 years old, so I can go back and go, okay, she's born in 2011, and there's the birthday picture from March 9th. It's probably something like Haley 3911. Her dog's name is Fluffy, and she's 13. I am not kidding you. I've been in offices after hours and go, gosh, I got to get into this computer and I blah, 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 blah. I literally, that's how easy it is to hack. One of the things that I just read in some geek thing that I read every night said that for password strength and security, and please don't use the same password everywhere, because that's a HIPAA violation too. For password strength and security, if you use an uppercase, so a lot of people do lowercase with numbers and special symbols. Those can be hacked within 30 minutes with the algorithms that these hackers use. The way to trip them up is to add one uppercase letter. So you want uppercase letters, numbers, lowercase letters, and special characters. I recommend using phrases and not words. Like, I like to go fishing on Saturdays, exclamation point. You know, something like that. Not password 1, not change me 123, not I hate passwords. Those, everybody knows those, right? But if you're using the same password for your EMR that you're using for your email, that you're using for your bank, you just got 3 things that could really do a lot of harm to your life. Because whoever just hacked into whatever organization that has your email address just got into everything. True story. My Facebook got hacked. I'm the perfect example years ago. And I was using my work emails attached to my Facebook. So I woke up on a Sunday morning and my phone, I wasn't a big texter in those days. My phone was literally vibrating off my counter. So I look at the phone and a couple of my employees said, I think you've been hacked, I think you've been hacked. Now, I gotta say, I love my clients. A couple of doctors said, do you need me to wire money? Are you okay? And I'm like, what's going on here? So I called somebody and I said, why are you sending me these texts? She goes, Julie, we're getting these weird emails from Yahoo that you are in London, your husband had an accident, you can't check out of your hotel, and we need to wire you money. Well, I was in Portland at the time. My people, my family that was here, and I have some family in Okinawa, they were still awake. So they were instant messaging them on Facebook, and they could see all my history. So my friends were like, some of this doesn't sound like Julie. So they started grilling them. Who's our friend that grew up in the same town? Well, they found her on my Facebook. What they also did, so I'm here to tell you, I've been schooled and learned, and I am not this person anymore. They shut down my work email because I was the administrator. So we couldn't get into email. They deleted my entire email server, which was hosted by somebody else. Thank God it happened on a Saturday night, overnight going to Sunday, because I was able to call my email partner. They had the Friday night backup. They changed my password right away. They had forwarded all my email to this Yahoo account. And then they were acting as me. 2 of my girlfriends, who are a little older than I am and a little bit too trusting, one sent $1,800. Her husband was dying of cancer at the time here. And she said, we don't really have the money. Can you send it to me as soon as you get home? And da-da-da. And I was like, what are you talking about? And then the other one had just Western Union $3,600. We were classmates at UH 30 years ago. And we know each other on Facebook. Like, she felt that, but she was the one that she kept questioning them. And then she said to me, you were being such a bitch to me on here that I decided I would never talk to you again once I got my money back. I felt horrible. So I called Facebook. There's nothing they could do. I called Western Union. We couldn't do anything except cancel the payments. Because I said, can't you arrest this person in London? They go, we have 3,600 London Western Union pickup points. We can't have a cop at every one of them to be waiting for the person. You have to cancel it. We had to call the FBI. We had to go through all of this stuff. My bad was I used the same email address everywhere and the same password in 2 places. 2 places only. Brought me to my knees for 3 months. But I was really heartened that some of my doctors wanted to send me money. I mean, literally were sending me text messages, go, where do you want me to wire the money? I didn't think I could reply to the email you sent. So let me confirm it's you. One said, you were just in my office yesterday, you're in London? I was like, in my dreams, I'm in London. So that's my final thing. Do password, password, password. There's a product called LastPass. I get no money for saying this. It has saved my life. It has saved my company. There's a free version. It puts all your passwords in it. You only need to know one password, your master password to LastPass. Every morning you launch LastPass. It's got links to all the websites you go to. If you've got billers in your office, trust me, they're going to about 50 websites a day to look up claims, to look up eligibility, to do all the things that they need to do. They're all using the same password on all the websites. They're sharing them with each other. Get everybody to change all their passwords, put them on LastPass. At least do it for yourself. And at least start to chip away at the security breach that's probably happening every day in your office. Anything else? Any other questions? I didn't mean to scare you, so I hope that I didn't leave you here going searching for a bucket. Thank you.